Okay, so I see we have 30 some people on the line, so I think we'll go ahead and get started. Yeah. Hi, everyone. Welcome to this webinar briefing on the 8th Annual DC Public Health Case Challenge. I'm Alina Bachu. I direct the Roundtable on Population Health Improvement at the National Academies. And with me are my colleagues, Amy, Maggie, Sophie, do you want to introduce yourselves?
Sure. Hi, everyone. I'm Amy Geller. I am a study director here at the National Academies and help run the DC Public Health Case Challenge with Alina, Sophie, and Maggie.
Hi, everyone. I'm Sophie Yang. I'm a research associate at the National Academies, and I also help staff the DC Public Health Case Challenge.
Hi, I'm Maggie. I'm a research assistant for the National Academies. It's nice to meet you all.
So again, welcome, and we're really delighted to have on the line, in addition to many of the members of the teams that are going to be competing this year, a number of their advisors as well. We are recording this webinar and we'll be able to share the recording afterwards so that your team members who are not able to join us are able to watch it at a later time. And of course, if there are any questions after the session, we are happy to provide answers that will be sent to all of the teams so that everyone is on the same page. And in addition to being thrilled that we're doing this in person this year after having to cancel it last year, since so many of the great things about the DC Case Challenge, Public Health Case Challenge, are lost in a virtual environment. And we wanted to make sure that we had all of those wonderful things. I'm also even more delighted to welcome today Sherry Johnson, who is a member of the Roundtable on Population Health Improvement and who is here to give you an expert briefing on the ecological model of health and how you could integrate that into your solutions. And I'll just tell you a few words about Sherry. Sherry has a PhD and she's been working in the field for more than 25 years and working with children, families, and community organizations and systems to advance health and well-being. And Sherry is a director of the Population Health Institute at the University of Wisconsin at Madison, where she also runs the County Health Rankings and Roadmaps program. And she is also a professor in the Population Health Department there. And Sherry has a degree from Brown University and degrees from Boston and a clinical fellowship from Harvard Medical School. And there's so much more I could say about Sherry. I'll just mention one brief thing, that she also worked for a federally qualified health center as a director of behavioral health. And I'm mentioning that because the FQHCs are near and dear to my heart, even though I've never worked in one. And I'm just a huge fan. And one of the reasons I like them is because they really integrate caring for the community with delivering health services and having a population health and public health perspective as well. So I'll turn it over to Sherry right now. Thank you so much for joining us today, Sherry.
Thank you so much, Alina. I've really enjoyed being a member of the Roundtable, and it's an awesome opportunity to learn and push the field. And I'll just share one other piece of background information. I am the proud mother of 2 sons, one of whom is finishing up at Howard. So no bias. I think Howard has a team, but just really glad to see all of the next generation of population health leaders here to start this challenge. So I have the task of giving you a briefing and an overview of population health and equity. And so I'm going to try to do that in about 30 minutes. So my colleague at the University of Wisconsin-Madison, Dr. Dave Kindig, is really one of the earliest thinkers in this field of population health. And he and his colleague, Evan Stoddard, define population health as both a concept and a field of study that combines the definition and measurement of health outcomes and their distribution and the patterns of determinants of health that influence outcomes. Importantly, they add the policies that influence the optimal balance of determinants. So that's a lot of words, and they were helpful in putting it in a somewhat more simplified schematic where you can see that policies and interventions at both the individual and society level lead to patterns of health determinants over the life course. And we'll talk a little bit about what health determinants are in a minute, but that those two things then lead to the distribution of health in populations and the distribution of determinants. And so even more simple way of understanding a lot of these words is through the county health rankings and roadmaps model. So this is a model of health that's used to spark action around the country by helping local community change makers understand a broad definition of health and understand the range of determinants that contribute to how long and how well people live. And Dr. Kindig's initial thinking, and Dr. Remington and Catlin and others at UW distilled the population health literature into this sort of easily digested graphic depiction of what are now largely described as the social determinants of health. And you'll see some of the same words in their more academic definition. So here is that important base of policies and programs that lead to health factors or determinants that then lead to health outcomes that in the county health rankings model we define as how long and how well people live. People pay a lot of attention to these 4 blue boxes because they really provide a helpful set of buckets to understand what are the main categories or determinants of health that can be measured at the county level and measured over time in ways that can help local communities figure out whether or not they're making progress toward advancing health. One of the misconceptions is that these percentages that we assign in the county health rankings model are exact and or that they represent the balance of determinants in every single place. What these percentages really do is help us to, again, use available data for what we know to be the primary drivers of health and weight them in recognition of what we know from the literature, but weight them in such a way that then also allows us to rank nearly every county in the country. So about 3,100 according to this model. There are critiques of the percentages that are assigned and critiques also of whether the universe of health determinants are represented in the model and whether we can even represent the universe of health determinants and whether they should add up to 100% or not. So those critiques notwithstanding, we know that this model has really helped a large number of people who are interested in making health improvements in the local communities in our country broaden their understanding of what we're talking about when we're talking about population health and what are some of the levers that they can think about pulling in order to make change. And so here you'll see a range of measures that we have available for nearly all of the counties in the country at the county level over time that draw from primarily publicly available data sets. So I hope that in your case challenge, you may take a look at the model and look at the available data to help you think about how you're going to approach the challenge for this year. So what do we know about the state of population health in the United States? Well, we know from this model that healthcare is, or clinical care, not the whole story, right? So access to healthcare and quality of healthcare is very important. We've certainly seen that in the COVID-19 pandemic, but it is far less influential on the overall health of a population than the general population and even folks working in health and healthcare really think. So in the US, we spend much more on healthcare than any other nation. And not surprisingly, for those of us who work in population health, those expenditures aren't leading to improvements in population health. And not only are they not leading to improvements, but they're not addressing the long-standing disparities that we see across multiple identities and social groupings. So either by education or socially constructed race or geography or neighborhood or ability status, that these investments that we're making in healthcare aren't really moving the needle. So how do we know this? So the Commonwealth Fund has recently published a piece of gray literature that really reflects many other studies that are in the literature that show that the healthcare spending in the US as a percentage of our GDP has continued to increase. From 1980 to 2019, you'll see that we are this top orange line. So we exceed healthcare spending by a visibly large amount compared to other nations who are considered our peer nations according to economic measures. So the Organization of Economic Cooperation and Development. So these nations are spending quite a bit less of their gross domestic product on healthcare. And what are we getting and what are they getting? So here we see in the next graph that the United States is, again, spending a tremendous amount on healthcare, but not getting the related health system performance that other countries are getting. So many ways of looking at this disconnect between what we spend on healthcare as a determinant and what we get in terms of improvements of the health of the population. Not only do we spend a lot and not get very much, but the money that we do spend on healthcare is also not helping us to make progress in reducing differences in health outcomes for what I am describing here as minoritized groups. And I chose that phrase on purpose to really underscore that racial groups are social constructions, and they really reflect a system of valuing some groups of people over others, and that system of valuing that we've taken on as a project in the United States and which has shown up in other countries as well is a social construction. It's a decision to decide who's at the top of the quote racial hierarchy and who's not. So this report from the Institute of Medicine was really a seminal report back in 2005, I think, that demonstrated that racial and ethnic groups in the United States receive lower quality health care across a number of studies. I think they reviewed about 550 studies in this text and just showed across many different aspects of both access and quality of care that African Americans, Latinx, American Indians, and some other groups are much less likely to get high quality treatment and high access to care. So even when income, insurance status, and other medical conditions are controlled or similar, these disparities exist in treatment. So what else do we know? So we know then that this notion that healthcare is the answer is insufficient. And simultaneously, we've seen the field over the last 100 years really move even more strongly toward the idea that healthcare and medicalization of the concept of health is the answer. So health has been largely viewed in our country at the individual level through the biomedical lens, but it's important to recognize that health, how long and how well we live, is not the same as healthcare, access to medical services, mental health services, et cetera. And that health disparities then, this notion of how long and how well we live, are also not the same as healthcare disparities. They are related concepts, and certainly these healthcare disparities that I just described matter, but we need to really widen the lens. And so a myopic policy focus on healthcare only, whether it's funding for healthcare, meaning reimbursements and insurance and et cetera, or whether it's access and quality, are really insufficient to get us to an overall population health improvement. And while there are some encouraging signs in terms of what's happening in healthcare, lots of healthcare systems starting to think about how they can address health-related social needs like safe housing or even housing period or access to healthy foods. These are encouraging and important ways to address the acute needs of the patient population in ways that we know affect things like diabetes and diabetes management, or asthma and asthma management. If you live in a home that has mold and mildew and you don't have the resources yourself to control those environmental exposures, then you have a health-related social unmet need, right? And so it's really important for healthcare systems to think about what their role can be in addressing those social needs. But that's really not the same as addressing the social determinants of health or the social determinants of equity. So this notion of health-related social needs is really at the most basic introductory level of understanding what really shapes population health and equity. And so the social determinants of health are defined as the circumstances in which people are born, grow up, live, work, and age, as well as the systems that have been put in place to deal with health status or illness. And that these circumstances or conditions are shaped by a wider set of forces, including economic, social policies, and politics. And so it's really this question and issue of, why are things the way they are? How did these circumstances that differ so dramatically by geography or race or ethnicity or language, how did they happen in the first place? And what is it that we can do to interrogate the processes that occurred to create the conditions? And most importantly, what can we do to undo policies and systems that have been created largely intentionally and with a large amount of government input? How do we then think about undoing them? If they were done, they can be undone. And so this notion that things are hopeless and nothing will ever change, I think when I get into that mode, I remember that if someone decided to do it in the first place, then we can decide to not do it now. So that really leads to this broader question also of health equity, which common definition by Braverman et al. Really begins to help us to think about an even broader set of determinants of health and equity. So including things like poverty, discrimination, and the consequences of those conditions that include powerlessness and a lack of access to jobs with fair pay, quality education and housing, safe environments, and healthcare. And so this concept of power and powerlessness is really going to be one that I'm going to come back to, and I tend to go on for too long. So give me a time check if I'm getting too close to our time. But the concept of power and powerlessness is really key to understanding how policies and systems get made in the first place. So back to that question of why are things the way they are and why can they be another way? They can be a different way because of this concept of power. Who has say so, who is at the table to make decisions, who has been enfranchised or disenfranchised in our formal political system. Those are the ways that decisions get made that then determine the conditions that people and places are living in, and the way that those places in particular are constructed, and how those places and the construction of those places lead to either better or worse health. So what's missing in the sort of simplified definition that Braverman and et al. Have shared is they talk about income, which is an important determinant of health, but the field is now even broadening its lens to understand that income is insufficient to understand these dramatic differences in health particularly for people of color compared to whites. And so the field is now beginning to think about wealth as another way of understanding how these differences emerged and why they persist. So this is a demonstration of the differences in median net worth by education level, also broken down by race and ethnicity. And what you can see is that white households with no bachelor's degree have a higher median net worth than both Black and Hispanic households that have degrees. And so why is this? Why do we see this type of wealth difference between groups? So one thing that's really important that is often not taught is that there is a historical context around the vast differences in wealth over time that again is an example of decisions previously made and a clue to the things that we might be considering to undo them. So for American Indians, this doctrine of discovery as a policy at the governmental level that was used to colonize and control lands that were occupied by multiple tribes continue to impact both land ownership and wealth. And so if we don't understand the policy decisions that have been made in the past, we run the risk of having too narrow of a focus on the types of solutions that are necessary in order to make transformative and sustainable change. Similarly, when we think about Black Americans, in particular, Black Americans who are descended from formerly enslaved people, scholars here, Darity and Mullen, have really written incisively about the role that reparations program for Black Americans could play in closing the wealth gap, and then using that closure of the wealth gap to anticipate the improvements in health and social outcomes that would ensue. And so for many of us, including me, this idea seemed, beyond reach, beyond something that could actually happen. And I think often without that type of radical imagination that scholars like Darity and Mullen have, and then the ability to rigorously study the ways in which a reparations program could be implemented in the United States, that the absence of radical imagination from academia in particular, I think contributes to the status quo. So I'm really encouraging you all in this case challenge to bring your most radical imagination to the table and then look for the scholarship and evidence to back it up, or begin to think about and hypothesize about what would be needed to back it up. So Darity and Mullen, through multiple versions of economic analysis, determined that between 10 and $12 trillion would be necessary to implement a monetary reparations program for Black Americans who are descendants of formerly enslaved people. And now 10 to $12 trillion doesn't sound like that much after the amount of spending that we've seen the government be able to marshal in response to the COVID-19 pandemic. So hopefully this is sort of piquing your thinking about how you might approach various public health challenges with the widest lens and with the most daring solutions that are in many cases long overdue. And so this social ecological model of health is one that I actually was trained in as a clinical psychologist. So my training is as a clinical psychologist, and also want to underscore that as, no matter what discipline you're training in now, there's a path to public health and population health. So my career started as a member of a healthcare delivery team, right? That's that FQHC world, and delivering direct services to children and families is where I spent a large chunk of my career. And the longer you stay in direct services, for many of us, especially those of us who are serving under-resourced communities, the farther out into this socio-ecological model you start to want to go. Because when you are in the trenches, so to say, dealing day to day with individual children and families and feeling an immense amount of satisfaction from being able to serve and help, there is that gnawing sense that there are things that could be happening that would prevent that child and family from ever needing to show up in your office in the first place. So whether it's a child who's been poisoned from unnecessary exposure to lead, or whether it's a child that's been exposed to too many adverse experiences, or whether it's a child who is struggling with a learning disability and is in a public school system that has inadequate resources, all of those presentations, those clinical presentations that I would see in a clinic, really are amenable to interventions far outside of the individual child or their family or even their community, and really beg for public policy solutions. So one example that, well, I'll get to that. So when we think about the socioecological model, there are these community level factors, and hopefully you think back to that county health rankings model where we had a determinant around social and family support. You might be thinking about intervening then at the social support level, at neighborhood service level, at the level of food accessibility, public education or transportation, or at the public policy level. You might think about, in addition to trying to find ways to support families and communities in building stronger ties, what kinds of economic interventions are going to both may also help families by reducing the stress of unmet financial needs. So what about the earned income tax credit or paid family leave or other types of further upstream interventions that are likely to have even more impacts on individual families, communities, and population health. So one of the things that So the social ecologic model really focuses on this broad array of factors similar to the population health model. And it really helps us to understand that health and health disparities are produced at multiple levels. And so we need interventions at multiple levels. And so this talk is not to suggest that clinical interventions or individual level interventions are unimportant. But if we don't intervene at every level of the socio-ecologic model, we're not likely to really move the needle on overall how long and how well people live. And that this notion that prevention happens the further upstream you go is one to keep in mind as you're considering the case. So lots of different models to think about. So I've shown you county health rankings model, which is an easily digestible graphic that is then connected to a wide range of data at the county level to measure progress. I showed you the socio-ecologic model, which is also an easy to digest graphic that shows that interventions can happen all the way from the individual to the public policy level. And this is an international graphic that really helps us understand both the social determinants of health and the social determinants of equity. And so this is from the Commission on Social Determinants of Health at the World Health Organization. And it's a little bit less easy to follow in terms of just looking at it. But what you can see here is their description of the social determinants of health that we've been focusing on. So what are those material circumstances? What are the behaviors, health behaviors that people can take? What are the psychosocial factors like social support and social connection? And how do they work either through the health system or independently to lead to health equity and well-being? So those are pretty familiar, but often in the United States, we pay less attention to the socioeconomic and political context, which internationally is well understood to be the more deeply rooted determinants of health inequity. And these include things like governance and macroeconomic policy, the cross-sector public policy in education and social protection, culture and societal values. And so this is an area in the United States that I think is beginning to get a little bit more traction, that we're beginning to have some conversations about the relationship between what we value and how that value translates into a narrative, and how that narrative then helps to shape what we think is possible or necessary. And so if we have a culture and a set of values that are focused on individualism and personal responsibility, and the myths of bootstrap, that I did this, I did it by myself, I didn't need any help, and therefore everybody else can do it too. If those are our core values, then it's likely that we're going to be less inclined to support the types of policies that reflect a set of values around interconnectedness and shared fate. And those types of policies might be things like child tax credits, or expanding earned income tax credits, or policies that might consider access to healthcare a human right, and then translate into, full access to healthcare for everyone. So this conversation is brewing, but I think it's also nascent in terms of how do we actually have a conversation about the ways in which our values are shaping our policy decisions, and what can we do to actually highlight or prioritize different values that might lead us to policy decisions that would improve health and equity. So that set of questions then can be integrated into the way that you're thinking about both intervening at the primary prevention or secondary prevention level. Population health really seeks to prevent illness from happening by creating the conditions that people need to live long and well. And secondary prevention is at that level of when a problem is at an early stage, can we still step in to reduce the risk of morbidity, mortality, or disparities? So examples of primary prevention that folks are probably familiar with: tobacco policies, whether it's raising the age for when someone can purchase tobacco, investing in educational attainment, whether that's investments in early childhood education, preventing early exposure to trauma, economic stability. So one of the aha moments that the field is having right now is around the number of children who have lost a parent as a result of this pandemic, and what that will mean in terms of the early exposure to trauma, and what do we need to be thinking about now to mitigate that exposure, because we're beyond primary prevention, it's occurred already, but what are the types of investments that we need to be thinking about to address the needs of what's more than 180,000 children who have been orphaned in the United States as a result of this pandemic, whose either parent or primary caregiver or grandparent primary caregiver has passed away. And the disparities by race and ethnicity for children who have now been exposed to this type of trauma mirror the type of disparities we see in all the other health conditions and health outcomes. So it's that kind of thinking, both about what the problem is and also what the solution might be, that I'm hoping the next generation will be better at. And so thinking then about what policy levers do we have? So there's often this conversation about big P and little p. So a big P policy, a definite course or method of action or inaction. So it's both what we decide to do, like a child tax credit or extension of unemployment benefits, and what we decide not to do. So to think of everything that we've decided not to do, or that we've had variation in what local and state governments have decided not to do in relationship to this pandemic. It's a specific decision or set of decisions designed to carry out a course of action, and it can be a program that consists of desired objectives. So think of things like home visiting as a program, but that there are policies that underlie early home visiting that support and sustain the ability of local and state actors to deliver those programs. And then what's even further under that big P, right, is this notion of power. So how do policies get implemented? They get implemented because people decide to do them, and those people are often the people that we elect. And so then we have to be thinking about what is missing in terms of who has the opportunity to participate in the decision-making process. So whether that's quite literally who is enfranchised as a voter or not enfranchised as a voter, but also all the things that surround the election of public officials. So things like access to, mail-in ballots or other types of either opportunities or barriers to participate in the democratic process. And we just hosted under Alina's and I a workshop on civic engagement and civic infrastructure to really better understand, in addition to voting, what makes these big P and little p policies happen, and how do we understand the relationship between civic engagement and civic infrastructure and health. So policy is both a cause of structural determinants, and vast literature shows it is the most powerful way to intervene. And we need to be careful about how we think about policy, both at the big P and small p level. So there needs to be some logic and evidence behind the intervention. So I don't have a slide here, but if you Google what works for health, it's part of County Health Rankings. It is a curated warehouse of evidence-informed policies and practices across the determinants of health that our tagline is, we read it for you. So our policy analysts have read the literature, analyzed the literature, and then rated the effectiveness of a range of policies and practices from scientifically supported to don't do it because it might do harm. We're also working on a disparity rating index, expanding that index because we know that some policies will have great overall outcomes, but they may or may not do anything to reduce the gaps between groups. So thinking about that as well when you're selecting policies. And so I'm going to try to wrap up because I think we're at the end of time. Just to reinforce that the social determinants of health and the social determinants of health equity are different, and that systems of power that determine how socially defined groups are valued are at the root of this notion of health equity. So this is Kamara Jones's thinking and work. And Don Berwick, who is one of the leading thinkers in healthcare improvement, has taken a lens of the moral determinants of health. And our colleague Daniel Dawes has also taken a lens of the political determinants of health. So you need to really expand to think about how moral thinking and moral foundations are driving what we decide to do or not do. And Don Berwick then challenges us to understand that no sufficient source of power exists to achieve investments required other than the discovery of a moral law within. And the status quo, particularly the status quo of the healthcare delivery sector and all the money you saw spend at the top and the vested interest in that system are too deep and too proud and understandably self-righteous, so that the moral force of our professional leadership, though, can also be powerful if it's grounded and mobilized. And so the question that he posed at the end of his piece was whether the health professions and their institutions ought to take on this direction. So we're seeing a lot of examples of people who do have the courage to have their voice raised up to make changes in policy. And we know that when those voices are raised up, that health equity can be produced across generations and the life course, and that we can develop both policy and interventions aimed at preventing and reducing disparities. And I made it in 30 minutes. So happy to take some questions or comments or whatever would be helpful.
Thank you so much, Sherry. That was just an amazing masterclass.
I think Anita, is that a hand up? Anita Novilla? Or is that just a nice job? Or
Yeah, that was me saying thank you. I mean, trying to use the reaction buttons here.
thank you.
I think there's a raised hand from Agrata Sharma.
Yes.
Thank you for the presentation. It was absolutely amazing. I think health equity has never been explained better. I just wanted to ask, since you're talking about the orphan children in the US, do we have some learnings from past outbreaks, say like HIV or other outbreaks that have happened? And have we done anything to protect the children back then?
Yeah, that's a great question. And the article in Pediatrics that I just read today actually compares the number of children who are orphaned as a result of COVID-19 to the number who were orphaned as a result of the 9/11. And just the magnitude of the number is so great between those who are now orphaned as a result of COVID-19. So I don't think we've done a good job learning the lessons from either the HIV pandemic or other mass traumas. I think the field in general has come a long way to understand adverse childhood experiences. And I think we are lagging woefully behind in thinking about what it would really mean to develop policy to both prevent, but also to then mitigate the impacts of the magnitude of loss that is being experienced in particular communities. So in the slides, I have the link to the pediatrics article, so you'll be able to read the article, but some of the things that they recommend are related to shifts in the kinship care system that's part of the child welfare system. And we need to act quickly because these children are suffering now.
Thank you so much. Thank you.
Thank you. Well, I think it sounds like you all have some additional logistic business to cover, so I will send PDFs to Alina and her colleagues and wish you all the best on the challenge.
Thank you so much, Sherry. So I'll turn it over to Sophie now.
Sure, thanks, Alina. So once this webinar concludes, I will send an email to all of the competing students and faculty advisors with the case document, as well as a document with tips and best practices. And the tips and best practices document has detailed information on what you can expect on the day of the event. So we encourage you all to read through that carefully and let us know if you have any questions. That same document also includes information on the COVID safety precautions that we're taking for the event. And we just want to remind you all right now on this webinar that everyone who enters the National Academy of Sciences building where the event will take place must be wearing a mask and must show proof of vaccination in order to enter the building. And so for proof of vaccination, you can just have a photo of your vaccination card on your phone if you prefer. You don't need to bring the physical card itself. Once you're inside the building, it will also be mandatory to keep your mask on at all times, except when you're eating and drinking. And you will also need to keep your mask on during your presentation. And I think those are all of the things that we wanted to go over now regarding logistics. If you have any questions about what to expect on the day of the event, you can email me or anyone else from the staff team. And I think with that, I'm going to turn it over to Red now, who is going to introduce the topic of this year's case. Red led the team of students who wrote the case that you're about to receive, and he also has participated in the case challenge for several years as both a case writer and a member of a competing student team. So if you have questions for Red, please feel free to raise your hand, or you can send them in the chat for him to answer. And Red, I'll hand it over to you now to introduce this year's topic.
But I think you were going to start with some best practices from your time competing and watching the competition as well before you shared the topic, I think. Is that right?
Yes. So can you hear me?
Yes, I think you were frozen for a moment, but we can hear you now.
All right. So how's everybody doing today? My name is Red Woldeselassie, and I'm the case lead for this year's case. And I'll start off with some of the best practices as far as being. Previously, I represented George Mason, and I competed. And I was also a case author in the past and also a case lead now. So the one thing that I would emphasize is make sure that everybody that you have on the team has enough time, then they're able to commit as much time as you can to make sure that all your information is put together. And don't be afraid to get creative with your solutions, and also make sure that you read the documents as you read the document and get all the details of it as much as you can. Make sure you brainstorm and make sure that you identify anything that you think is relevant to the solutions that you present. And make sure, the one thing I'll tell you is make sure that you devote some time to really have a full and creative presentation. And also, most importantly, have fun with it. This is not supposed to be stressful. This is not supposed to really cause you any type of, excessive stress. Have fun with it, learn from it, and make sure that, you present all your solutions in the appropriate and best manner that you think is possible. So from that, moving on, the case for this year is going to be addressing infectious diseases using population health approach. And the more specific topic is going to be prevention and control of bacterially sexually transmitted infections in young adults in ages 18 to 24. And as you will read in the case, once you get it and you start going through it, there are specific reasons why we selected this subgroup, but the writing team and I, we had time to sit down and brainstorm and really look at the data, look at the information, and see where we need to put our focus on and come down with the narrow topic. So with that, does anybody have any questions so far?
And these could be questions about anything since Red was a competitor, these could be questions about, what to expect, things, anything to do with planning for the event at the day of, and any questions about preparation or anything like that. And also any logistical questions that staff can also answer at this time.
All right. If not, I will pass it back to Sophie or Amy. Can you share any lessons learned? I'm reading the chat questions. Sorry. So lessons learned as far as competing or as far as like preparing your documents. Competing, make sure that you and the team have time really to sit down and brainstorm. And also when you do come up and you do your presentations, make sure that you practice, not necessarily write out a script or whatever, but make sure that you are comfortable and ready to present. And also whatever solution that you propose, make sure you know the details of it and make sure you're able to answer the judges' questions. A lot of the times when judges ask questions, and you are on stage, it feels like you're being put on the spotlight. But just make sure that you understand the question and you calmly respond with the information that you have. What template recommendations do you have for how we should structure our intervention presentation?
So Red, maybe you can talk a little bit about how your team handled that. Well, if you can remember, it was a while ago now, but we don't have a specific template. So it's your job as a team to think about what is the most important information you need to share with the judges and how you want to display that information. I'll talk with Sophie and Alina, and perhaps there's examples we can send from past years, but I would talk to your advisor about that as well, because I'm sure they'll have good suggestions, but there's no set way or set of information you should share. You'll see in the best practices document that we point out that you can also include appendices or additional information, appendices in your slides in terms of deeper information than you might be able to get into in your presentation that the judges can look at. The judges spend a good 2 hours deliberating. So they spend time looking, we'll have copies of your slides for them. And so they'll be looking at those, looking at the more details, the details of your budget and any other information you provide. And some teams have given other supplemental information to them as well. So you should basically design it the way that you think is most effective and most effectively gets across your solution. And then I see there's a question, how do you recommend the group work should be distributed and how long do you recommend spending on individual work? So that's going to be up to you. As you're a multidisciplinary group, you're going to be coming from lots of different backgrounds, and I'm not going to lie, that can be tricky and that can be challenging, but that's one of the beauties of the case, beautiful things about the case challenge. And Red can probably actually talk about this a little more. So I'm going to pause after I answer. But you'll decide, some teams say, okay, you're going to take the budget, you're going to take this, you're going to take that. Some teams work on everything together. It really depends on, in part on schedules and in part on, how you decide you want to move forward with your presentation. So that might be an unsatisfactory answer, but we kind of want you all to figure that out as a team and make a game plan. So Red, for both questions, I'm going to step back and see if you have any advice or suggestions as well.
Yes, so the first thing is meet with your team early and identify who has specific expertise in what. You don't have to be really an expert in one specific thing, but understand who's comfortable with doing what sections, right? And once you do that, plan to meet as frequently as possible. You have 2 weeks, I think it's 2 weeks, right? Still 2 weeks? Mm-hmm. Yep, you have 2 weeks. When I was competing, we met almost every day. We created group chats, we created Google documents, we created a Google folder where we had everything. Any changes that were made by a team member, we identified them. We were able to track all the changes that were made, and also designate somebody in your team who will act as the lead, who will act as somebody who's going to coordinate your calendar, somebody who's going to coordinate the meeting times. Just organize your team as much as possible. Then during meeting times, set deadlines, create these deadlines of what part of your presentation you want done on what specific day. And once you do that, delegate your tasks to the different team members, make sure everybody meets the deadlines, make sure everybody has something to present to the team lead or to the team when you guys are conducting your team meetings. The main thing is stay organized, plan your time accordingly, meet frequently, whether it be on group chat, whether it be on Google, whatever is comfortable for you, and just make sure you communicate and, more importantly, have fun and get along and have a good time with it, and you'll have fun.
One thing I'll just really quickly add to that is that it's also helpful to think about the judges' questions, if you can sort of like brainstorm what those questions might be. And then once you have members of your team clearly designated to specific parts of the presentation, it'll be much easier for you to handle the judges' questions too, because you'll have, if the question relates to something that one person of your team worked on specifically, then that question will be for them to answer. So that's just another tip to help you with your presentations.
Yes, I agree with that. And then regarding this question, should we be presenting, are you going to be presenting to a naive audience, or should we be reasonably assume that the panelists will have a basic level of understanding of public health? So we will have a multidisciplinary panel, just like we have multidisciplinary teams. And we, sometimes have community members, we sometimes have academics, sometimes we have folks working in the field, and it will be a mix as usual. However, I don't think it shouldn't matter, because the presentation you give is a solution, right? And so you would need to clearly articulate your solution, make it very clear what you're doing and how, and then it shouldn't matter if the judges have a background in public health. They will all be asked who have read the same case challenge that we're releasing in just a few minutes. So, they'll all have read that and have the same basic understanding you have of STIs. Some may be expert in sexually transmitted infections, some may not. And they will though have that same background information that you all received, if that's helpful to know. We also release the names of the judges and their affiliations 1 week before the event, typically. Actually, we didn't make the team decision for this year, but typically it's about 1 week or at least a few days before the event, and their bios. So you'll have a sense of who you're talking to. My one piece of advice, having watched the judges before, having observed this for so many years, is stand by your solution. They're going to ask probing questions, and it's not necessarily because they don't think your solution was good. It's because they want to see how well you thought it out. And so don't, if there's something missing or something you've admitted, you can acknowledge that and acknowledge how you would address it. You shouldn't make things up, but you should stand by your solution. You should, you've given a lot of thought, you'll have put a lot of thought into it, and you need to really defend it and stand by it. But anticipating, what gaps you have, because obviously in 2 weeks you can't do everything, so that you can acknowledge those up front is also really important. Our pleasure. So we've got 2 minutes and we're happy to use them if anyone has any additional questions.
Regarding acknowledging gaps, I was going to say that that's very similar to acknowledging limitations. If you're writing a scientific article about research that you've done, you're just being honest about what the limitations were. The judges will respect that. If you say, yes, we are aware that we omitted or that we were limited to these, 2 considerations or whatever. So just be thorough in your thinking about it and how you describe the limits of it.
But do you want to mention, there was a question about budgetary constraints. Do you want to mention to the team the budget for this year?
Yes, so the budget that we agreed on in the case for this year is 2.5 million across 5 years. So it'll be on you, on the team to decide on how you want to divide that up based on the solution that you proposed. So, I mean, you'll have to take a lot of things into consideration when organizing that. So that's kind of where we're at. I would tell you more but I can't without giving you solutions. So I think it's on you to get creative with it.
Right, and then that's what it's pointed out in the case that includes staff time. And one little pointer I'll point out about budget is if you can't figure out where to place all your money, 2.5 million is a good amount of money, and depending on your challenge, you may be stretching where to spend it. If that happens, don't just make sure you have a specific plan for all the money. That's all I'm going to say. The judges don't appreciate unthought out answers of like, oh yes, well, we'll just have this $30,000, $50,000, $100,000 off to the side just in case we need it. Like, you should have a well thought out plan. Not to say you can't have money for backup, but you should also have an alternate plan then for if you don't need it for that backup, then what are you going to use it for? Just throwing that out there. Okay, well, I think we're at time. Okay. Well, I know Sophie is going to be busy sending you this email right now with the case, and she was going to wrap it up, but maybe Sophie, since we're right at time, I'll just say thank you so much for joining us. As soon as Zoom lets us download the recording and we get that all set, we will send that to you along with the resources that were put in the chat. Sophie is about to send you the case challenge, some best practices, including many of the tips that were mentioned today, plus many more, and a one-pager about the case challenge. And you'll see why in her email. And we're really excited. We can't wait to hear what you come up with. STIs have been rising for a decade, and there's no reason that they should be, because we know how to treat and prevent them. So we're really excited about this topic and know that you're going to come up with really innovative and, as Sherry said, radical and daring, but yet at least somewhat, feasible solutions. So thank you very much, and we'll see you in a couple weeks. Thanks, everyone.